So we know that our armamentarium tool for the diagnosis is evolving day by day, and the digital pathology and AI, which is collectively called as a computational pathology, is regarded as the future of pathology. And many people believe that in very short period of time, they will either sell their microscopes, and there are some university or some countries where they have gone completely digital, although we have not reached till that stage. Some countries also has stopped training the residents on the microscopes, so all their trainees is on the screen. So till the time we reach to that stage, we can't expect that will become complete digital. So as we know that digital pathology is as how it is different from the conventional routine microscopy. Here we see the same things rather under the microscope on the computer screen. But are we ready to replace the tool which has worked for so long for us, and we are quite comfortable with us? The reason for that is because there are so many benefits you can get if you are using digital pathology for your routine clinical workflow, because they not only improve the analysis, better viewing, and quality of your reporting, but also increase the productivity of the pathologist. So I like to touch up some of these applications, and these are the main applications where this tool can be used right from the education, where the initial role has come, and then it was predominantly restricted to the research. But now slowly the field is evolving to integrate it into the clinical practice. So that's why there is a lot of push now for the pathologist to adopt this technology and to get accustomed to it. And if you aim to use the digital pathology for the primary diagnosis, rest of the all applications, right from the education, research, and all other applications fall into the place. So if you are trying, if set, you're either you have a setup of digital path or you're planning for the digital, the aim should be to focus on the for its utility in primary diagnosis. And even even in TMH we are trying to push pathologists, but still many of them are not are very comfortable using the conventional microscope. But the freedom in our center is up to the pathologist whether they want to report digitally or using the microscope. But in future, I believe that most of the many cases or many pathologists will adopt this technology. So as I mentioned, the viewing of the cases will be on the screen as compared to on the microscope. And there are a definite advantage of using it, because you can objectively measure the tumor dimensions, the margin assessments, which are very crucial for the clinical decisions. So those things can be done more precisely. When we evaluate any case, you can do the comparison or the type of expression of the immunohistochemistry in any particular case very more precisely. So if you start using it, you will enjoy, or there is fun doing the reporting on these digital platforms, because they give a lot of flexibility to the pathologist. So, but before you start using it for the primary diagnosis, there is a recommendations to first you have to validate the system for routine reporting. And there are guidelines from the CAP or RCPath to adopt this to use them. And we also did the same for the various type of applications. And based on our initial experience, we found, except for the cytology, there was a very good concordance between the microscope versus the digital screen. So there is a good so this such a type of validation not only help us to prove the utility the utility of these applications, but also helps in the training of the pathologist. So everyone should, before they start using it, they should do these validation using at least 60 cases. And with experience, you will come to know there are some areas where there can be challenges in interpretation of using the digital tool, like identification of micromets, focal dysplasia, or if the foci are very small. So although there are assisted tools which helps us to pick up these the foci also, but you can, if you're using digital for primary diagnosis, better to make some checklist of the challenging cases. Real time consultations are very easy, and you can, if you want to take opinion from anyone across the globe, you can do it on the click of button. It also gives you great help in giving the opportunity to the education for the inter-department meetings. Those can be, it becomes more interactive. And even the multidisciplinary tumor board meetings, where the clinicians usually earlier they don't understand what it is under the microscope, so they uh, is there.
I think somebody needs to mute.
Yes, I done, sir, already.
Yeah, there are for good for the multidisciplinary tumor board meeting. So this is the opportunity you can showcase this technology to the clinicians or administrator, and convince them to acquire this technology, or even buy additional scanners. So you can engage this technology even for the workshops, like we do it very frequently for our EBUS rose workshops, where we demonstrate the clinicians like the utility of this remote reporting, which has come especially in the era of the COVID. So this is the one of the main application which has provided the flexibility for the pathologist to work from home, and we also used this technology and publish our experience. So there are multiple applications, as you must have seen, but still there are barriers to adopt this technology. And the major barrier is, which is talked about, is about the cost. But if you see the overall benefits of this technology against the hindrance, or are far more than the actual barriers. So in addition to the cost, there are some concerns, like technical issues to use this technology, or even the culture, means to shift from the microscope, that the resistance or the hesitance among the pathologists are also one of the reasons. So if we have to go digital, then we have to make a strategic plan, and the strategic plan includes the to forming a team. And as we have done when we adopted this technology, we include a team of pathologists, some people from the laboratory side, who are familiar with the routine workflow. Then you have to involve the people from outside the department, especially the IT people, biomedical engineers, and hospital administrators. So that, but the lead has to be taken by the pathologist. So unless until you push them, no one is going to give you a scanner. So if we have to get a scanner, so you have to make your implementation strategies depending on your key clinical requirements. So my requirements might be different from what are your requirements. So you have to invest depending on your actual requirements, and develop your scanner selection strategies accordingly. Next important thing, it is not only the scanner, but there are many other things also which are also required for the successful uses of digital pathology. That means includes building up a good image database and integration into the routine workflow. There should be a good image viewing devices, or the monitors, or the viewing software should be as user friendly as possible. And when you are set up with all these things, and then you have to go with the validation and training of the pathologist, and then only you can go. So that means it is not just a scanner. You have to keep in mind about the other things also, unless until you especially give the attention towards the storage and the routine workflow, the digital solution will not be complete. So as I mentioned, the acquisition of the scanner will depend on your clinical applications. And so whether are you planning to use it for the primary diagnosis, or teleconsultation, or research. And intended use was, if it is for the primary diagnosis, then we have there should be the aim should be to integrate into your existing LIS and EMR system. And if the idea was for the teleconsultation or remote reporting, then the idea was for then you need a good high quality internet connectivity outside. And even the slide type of slides which you use for this, it also depend on the intended use. For education or image analysis or some research, you can use the selected slides for the scanning. But if the intent is for the primary diagnosis, then you have to scan all the slides. Type of scanners which can provide you option. There are multiple options are available, and many of them are very close to each other, and if you it is very difficult to find out the differences, but if you see the specification of these all scanners very carefully, you will find the subtle differences. And that's why it is recommended, before adopting this technology, you have to pay attention to this scanner specifications very critically, so that you should not regret at the last that I have done the investment in the wrong system. So what we have done in our center, before we acquired these scanners, we did a comparative an evaluation of various systems, and even publish our experience. So we found that these are the key components which should be evaluated on site, using your own cases, scanning performance, how much time it take, and how much storage is taken. And you will there are some pros and cons of each scanner, but it will also help you to choose the scanner which will give you the best possible results. As you can see, these are the images from 4 different scanner of a same tissue. There is the colors which are produced are different, so you need a system which provide you the best possible solution, which matches your the microscopic inputs. And in addition, these scanners, no system is perfect, and you can get some artifacts. These are the various types of artifacts which are produced by the scanners. So the system should have as minimal as possible artifacts, because if you start using it for the primary diagnosis, and then you can't say that the error in my report was due to this particular artifact. So now currently we have 5 systems in different capacity in our department, and we, depending on the initial evaluation, we use them for the different clinical utility. So the systems, if you have, you can dedicate them depending on your requirement, and also on the capability of one system over the other. So after the scanner, as I mentioned, that the data storage is one of the crucial component, and you have to invest on the storage, depending on your storage or archival policies. And although there are, till date, there is no clear-cut guidelines in India about the archival, but we have given proposal to NABL to include that also, because many labs are now going for digital solutions. After the scanner and data storage or servers, then the integration between the LIS and AMR is the one of the most crucial component. And it is just to give you the snapshot of the design which we use in our system. So now our system, we can use it in-house as well as from the outside. Although there is when you're using the system from outside, there are some issues related to the data security or the speed of the internet, which we are trying to resolve. So the integration is one of the more challenging job which you have to face when after the system is acquired. And this integration is very crucial because it makes your life very easy if the integration with the LIS is completely done. And for this, at our lab, what is recommended is the slide should be barcoded slide should be used, and so that they can be tracked easily. If you don't use the barcoded slide, there is no use using this facility. And even in our workflow, we did many changes in the routine workflow, so that these things can be adopted very easily. Just to give you one example, these are the HE slides, and we have a single linear barcodes over here, which can be easily read by any scanner. But the IEC slides, which are produced by Ventana auto stainers, they have barcodes which is not for the slide numbers, but for the program. So when you put these slides, they will not come together and sit together in one place. So we initially did some jugaad method, where we put some additional stickers on the on these slides so that they all can come together. But at the end, the aim is to have a uniform sticker barcodes where you can avoid the work, putting additional works to your laboratory staff, and it also reduce the failure rates. So this were about the in brief about the background about the setup of the of digital solutions. But you have to keep in mind, if we have to use it subsequently, then the that will depend on the good quality of the digital images. And for that we have to pay attention to the pre-imaging factors. So unless until you pay attention to the pre-imaging factors, like you can see some bubbles or some artifacts in the tissue preparations, and talk to the your laboratory people on a regular basis, you will not improve the quality of your digital images. So our journey of establishing a digital pathology solution in TMH was took a long time. And you might also sometimes people feel that TMH has a luxury, but of many things, but the things to establish it also takes some long journey. And but once we got this scanner, and there was a good push from the team, and now the things are moving very faster rate for us. But still, I agree, in many centers in India, there are very limited facility for digital pathology. And if there are some private vendors, they have started offering the services, or like a referral services for only for the scanning. But there are only very few centers which are, you can say, they are early adopters of digital pathology in India. But at the same time, now if you see how the field is evolving, considering its utility in the AI, it is evolving at a very rapid pace. And there are multiple applications of digital pathology which can be combined with the AI algorithms, and they can give a lot of information which a clinician require in an era of precision medicine, right from the response prediction to the survival prediction and even the mutation prediction. So there are multiple applications where these models are being now tried across various tumor types. And I would like to touch briefly upon the applications of AI into the routine diagnosis. So what are these? How does these AI-based application or computational pathology based application works? They works on the same principles in which we use to evaluate our glass slides under microscope. Means there are some applications which are at the cell level, where the AI algorithms will focus on the nuclear segmentation, nuclear features, or the mitotic count. There are some applications which are developed at the tissue levels, like for the tumor detection or segmentations, or margin predictions. So they are based using the tissue or at the whole. And now the field is the new models which are being developed. They are including the clinical data also into the play. So that we at the end there will be a holistic model which can give you the more precise and relevant information in this era of precision medicine. So this is the workflow for the adoption of any or development of any model. So first and foremost important thing, you have to keep in mind what is your actual problem for which you want to use these any particular AI based applications. Try to look for its pros and cons, whether it is really relevant for it. If you identify, then you have to use it on for the validity of that is tested on some data set, and where the role of pathologist, as we have to curate good and pure data which can be used for the development of the model. And once that model is developed with the help of the engineers, and then it undergoes the performance evaluations. So first is the validations, technical validation of the model, and followed by the clinical validation, and then it comes into the final deployment stage. So you can see that there are a lot of challenges in the background, and we most of the time we see the end product in the front, but there are many things which goes in the background. So the applications of these into the clinical practice, especially in this era of precision medicine, they are quite broad, and right from the diagnostic, prognostic, and predictive assessments. Now the role is evolving in many across many tumors and across many fields. These are some of the common applications, and I will try to touch up some of them in my subsequent slides. So first and foremost thing, when you have to use any digital image analysis software, uh, uh, where to go and hunt for them, that is the question. So there are many companies who are already moving doing their job for us, and as a pathologist, there are very few of us who are really keen to go into the nitty gritty of these models. So if you are not a very pure, you don't have a pure engineering set of minds, so you can go for the ready-made solutions, and but understand the nitty gritty of these solutions, how they are developed, in which data set they were those were developed. So if a model which is developed in a Europe or USA, is it will that be applicable uh, to the Indian scenario or not? So there are some companies also which are Indian based, like Arya Metrics and Curative. They have come up with some solutions. And in addition, if you don't want to invest on any of these, or you don't have any resources, there are some options like open resource free software also, in which you can do some limited analysis, like QPath and ImageJ are one of some of these solutions, so which are free of cost. So but there are market of this software is now evolving and growing at a very fast pace. And I apologies for the small fonts, but just want to say that there are many models which are there, and majority of them are developed in the breast, and some in the GU, or for the prostate, lung, and colon cancer. And if you really want to check, if you want to either do it either for the clinical use or part of your research, or the thesis, want to check for anything, you can go to this website, that is empire.org, and they have list of all the clinical models which are now entering into the market. So you will get in the beginning what are the options available for for the your intended use, and you can contact the respective vendors accordingly. Now the you have selected some identified some application of these. Now how to use them in the clinical practice, that is another hurdle. So I'm don't blame me that I'm all talking more about the hurdles, but although picture look very rosy or green on the other side, but these are the nitty gritty of AI and computational paths you have to understand. So if you have a scanner, you have a defined model which you can use, or a software which you can use, but if the scanner don't allow the crosstalk between these two, you are again stuck. So now recently, now there is a push to develop the vendor agnostic image viewer, which can where at one solution or at one platform you can solve all your problems. You don't have to export the images and then upload it on the another platform and start doing the analysis. And the market for these vendor agnostic image viewers which provide these capabilities are also increasing day by day. So just to give you an example, this is the Visiopharm KI67 or MIP1 model, which is integrated into our Philips workflow. So we don't have to push images anywhere in or out of the system. So and in less than 1 minute, I can say in 30 to 40 seconds, it gives the evaluation on the screen, and you don't have to move from one place to other. So for the implementation of these models in the routine clinical practice, we have to need a close collaboration between the AI developers and hospital IT team and end users. And the models which are used, they should be generalized, then they becomes of the clinical utility. And to move forward, there is a need for the generation of annotated database, so that these can be properly cross verified and cross validated. There's a need keep a control on the pre-scanning factor. So even if you are not using any of the models right now, develop a good image database, so that in whenever in future you want to use this any of these applications for the clinical practice, you are ready with a good quality image data set. So both humans and machines, we need each other to survive. And now let me discuss some of the clinical applications of these AI and digital path and AI based models or the computational pathology tools. The first and most common is whenever we talk and a slide come to us for the diagnosis in a clinical suspicion of the oncology, the first question arises whether there is a tumor or not. So there are AI based models, especially in the GI cancers. They were developed where they can predict the probability of the cancer. So in GI malignancy and even in the prostate cancers, where not only the identification of the tumor, but also they are providing the information about the Gleason scores. So in a way they are trying to reduce our work slowly and slowly. So how does they work? They work on very simple principle, because uh, computer science is like it works on the binary numbers like a 0 and 1. So for them there is no gray zones usually. So that's why how uh, these AI models are still not it has become generalized till date, because they feel these models, they believe in that they can easily distinguish benign versus malignant. And so for them it is either 0 or 1 or plus or minus. So how does it works? Like just to give you examples of some models which are in the identification of GI tumors. So there are like three types of model, like a semantic models. Here segmentic models means it is distinguishing this between the stroma versus gland. So there the first this application is between the distinguishing between the stroma and gland. Instant segmentation, where they look for the configuration of the glands, is it the normal or abnormal, and object detection when they go more deep into the into the nuclear features. So these are the common applications which are used. And now recently a very good outcome data has started coming, and which is being tested not only in one in this study. They have showed they have tested it on the multiple data sets, and the results were quite exciting, as the distinction between the normal and the tumor, and even the various components of the colon, like glands, muscularis mucosa, stroma, those can be was very made very precisely. And now the using these applications into the more depth, uh, now that there's a push to not only evaluate to make a common model, AI based model, which can look at one go into the gland segmentation, means gland configuration, even the nuclear segmentation, because in the, as we know that in the colonic cancers, we can see either common type of necrosis or any secretions in there, nuclear segmentations. And so all these features are combined together to give, and when they are done like that, the results are very exciting. And the prediction of the cancer is now using these has become more than 95%. And not only they identify the tumor, they can even and pick up the, even if there is small focus of like a signature cell adenocarcinoma, or the which is one of the poor prognostic factor, those can be picked up more easily. uh, our team has recently participated last year in this Samicol challenge, which was released was a part of European Congress of Digital Pathology. And where the task was to identify, to distinguish between the various component of the GI biopsies, as well as the resection specimens from tumor, and even the various subsets like mucosa, mucin, necrosis, necrosis, muscular propria. So, and at the end you have to based on the evaluation, the model has to give the results whether the tumor is present and not present. And I with our team has done a very fair job, and we stood third in this challenge. And so this has give this challenge has gave us some confidence that what we are doing in this field is good. And now the winning a challenge is not the should be the goal, but the goal should be to adopt it into the clinical practice as easily as possible. So the next application is about the tumor quantification. So these AI based models gives more precise estimation of the tumor, and where it is required especially for the molecular tests, especially in the lung cancers and small GI biopsies, where the tissue is a very crucial component. So and even in the if you want to do the further studies in the precision oncology, where the tumor stroma segregation is required, so it gives some more robust information. So you scan a slide or run through this software, and at the end, when before starting of your molecular test, that you will get a precise answer how much percentage of the tumor is present and in which area of the block the tumor is present, so that you can guide your technician in the molecular lab to do that, to select that particular area of the block for any further molecular testing. uh, Further development in the in these lines is for the tumor pattern recognitions, as was used mainly for the prostate, where the Gleason scoring is now being offered very precisely by using these models. And even in the lung cancers, because where the pattern of the lung adenocarcinoma decides the grade of the tumor, whether tumor is lipidic, acine. So once the training is done by the pathologist, where your initial role comes, but once the model is trained well, then your role becomes only to the verify the results which is being offered by these models. Another application is the prediction of the lymph node metastasis, where these some of these models are working quite well. And maybe in future, when where the residents in our medical colleges, they spend nights screening these slides for the presence or absence of the metastasis, their job will become quite easy. But the lymph node metastasis is a little difficult as compared to the other applications, because the metastasis is pattern can be heterogeneous. There can be very small or micro metastasis in the node. And there is a that it also depend on the type, because there are various type of tumors across various systems. So there is need to develop a model which can be generalized, uh, uh, which can be generalized and apply and can be applied across various tumor types. There can be heterogeneous pattern of growths. As you take example of GI cancer, it can be intestinal type, diffuse type, or signating cells. So these can become challenging, and identification of micrometastasis is a issue. But recently we have this field also, the very good results are coming up. And even there is one study which is published last year, which 2 years back, which showed the almost 99% sensitivity of for predicting the gastric metastasis. So main work right now is in this field is in the gastric cancers, and some work is done in the breast cancers. But this field role is evolving in other applications also. In these, if you're using it for the lymph node metastatic prediction, the main problem is whether the algorithm can pick up these micro metastases and the cases which are subjected to the adjuvant neoadjuvant therapy, and the changes in them. So till date, none of these application models are 100% soundproof, and there will be some false positive and false negative results. But even we have seen among the pathologists also, there is a inter-observer variability in picking up the notes. Next application of this is in the biomarker predictions, which is required for the in this era of the precision oncology. And ISC based biomarkers or molecular based biomarkers are commonly used. I'll discuss some of the ISC based biomarkers, where the AI is taking a very promising role, because they are based on the objective criteria. And how so the prediction of for biomarkers is the initial workflow is same as for the any conventional glass slides. But if you want to look for any particular biomarkers, and then after the scanning, that ISC slide is subjected to a second second software which helps in the quantification of that particular algorithm. So the workflow is like that. There's a tissue first. The tumor, the represented tumor tissue is identified. The background quality check is very important when you are using these for the ISC interpretation. So background quality check for any digital artifacts. And now these uh, there are some algorithms which are incorporated while developing these models, so that any confounding factor results due to these artifacts can be absoluted. Then the intended cells are detected, and depending on the application of the model, whether it is a membrane based like for the HER2, or nuclear based models like for the ERPR, they are tested, and finally output comes on your screen like final results, whether it is a positive or negative, and if it is positive, what is the intended score for that. So if you're using these AI based models for the IC interpretations, then first and foremost is because there are a lot of applications, and uh, each biomarker might need a different model for the testing. That is the problem while using it in the clinical practice. So what is the intended applications? What is it? Identify a reliable AI based algorithm which is properly validated, integrated into the clinical workflow. And well, first, before you start using it in actual cases, validate it, and if any tweaking or is required, that is to be done, and then train all the stakeholders. So before you start reporting, training is very crucial, and then only you go. So these are the few of examples of commonly used biomarkers in the era of precision medicines, like ERPR, HER2, Ki67, and PDL1, and for tumor identification, like cytokeratin and multiplexing IEC. If you're using, then image analysis is mandatory. So I'll just briefly touch a few of these examples. ERPR, that is, there are many companies which are working on it, and why they are started working on it, because this is relatively easy models to develop, because they have to focus mainly on the nucleus and the staining and the various staining patterns. So the initial you might have seen there are many companies who are offering the testing for ERPR, and the results are also quite straightforward, at positive or negative. The problem comes when whenever there is a heterogeneous type of staining, like you can see in the figure C, when there is a variable intensity of staining. So in those cases, there is a real test of the model. So what we are using in our practice, we have adopted this Visioform 4-gene panel, that 4-marker panel, ERPR, HER2, and Ki67 in our routine clinical practice. So the cases which are scanned, they are a region of interest is selected, and within a fraction of second it gives the exact result. So do you need it in all the cases? I'm not saying you need it in all the cases, but wherever you feel there is a variability, or the cases which are on the borderline, in those cases if you use them, it gives you very precise answer. Next question come, if I'm adopting any AI based applications, then sorry, there's a matter of concern that the platform which I use for the performing of these slides, or even for the scanning of these slides, can have impact on the results. And people are also working on that, testing these models for across various staining platform, or even various scanners. And this paper has showed that using ERPR for Roche platform IC stainer, and Ki67 using DACO stainer has given more reliable answers. And although differences between the scanner wise was very minimal, but there was some variability which we have to keep in mind, as none of the solution in today's date is 100% perfect. HER2 is another biomarker which for which these applications are being used, and now there are few AI based few algorithms which got either CE or FDA approvals, and even CAP has also given some recommendations if you're using these similar to the guidelines which are proposed for the HER2 or HER2 interpretation either by ISC or FISH. Now there are recommendations for if you are using AI based application. I'm not going into the details of all this because these recommendations are mainly for the validations, and but what is important, if you are using or any algorithm for testing, then if it is FDA approved or CE-IVD approved algorithm, then 20 positive and 20 negative cases are sufficient. But if the algorithm is not CE-IVD approved, then you have to increase your number of cases to the 40, and there has to be 90% concordance for the positive samples and 95% concordance for the negative samples. And if there is any change in the protocol right from your staining or even scanning protocol, then the revalidation of the algorithm is recommended. There are some futuristic applications of the AI in ISCs, and one of them is pre-ordering of the ISCs using these algorithms. The good example is a prostate biopsy cases where you can see if the cases are scanned and the algorithm is run. So before or actual ordering of the ISC by the pathologist, these algorithm they give the message that these particular case out of, suppose if there are 10 cases, they will give a message to the pathologist as well as to the lab that these cases need ISC. And when finally the pathologist report a case, he will the case will come along with the ISCs which are decided by these algorithms. So it saves a lot of time and even avoid unnecessary ISCs in those cases where it is not recommended. And now there is some talk is also going about the virtual immunohistochemistry, means the prediction of the biomarker status based only on the HE images. So this is being tested nowadays in breast cancers, where ERPR or HER2 status can be predicted using only the HE images, and even in the lung cancer, where you can predict the mutation status for EGFR using only HE images. So if you have upfront information, like suppose if a case of lung biopsy come to me, and in the beginning only, if I get an information that this case is the EGFR the likelihood of positivity is quite high, I will try that patient for the testing first, so that the patient can be started on the therapy immediately. Next application is on the using Ki-67, and as we know that Ki-67 evaluation can be sometimes tricky, and variability is there, and the gold standard is to count the Ki-67 using captured images, which is usually very difficult and time consuming, and many pathologists don't do so. These image analysis softwares can give more precise evaluation of the Ki-67, and so it is very much relevant for the neuroendocrine tumors and even in the breast cancer. But one thing, if you use these algorithms, you have to keep in mind that for Ki-67 the staining intensity is variable. It can be either dark or it can be light brown. So the algorithm has to be tweaked so that it should not miss even the weak positive stain, and at the same time it should not take any negative stain of also that can also show some variability. And this is one of the good paper where the various application where they have compared the diagnostic utility of various AI based algorithms for Ki-67 evaluation. And the gist of this paper was that these applications, they improve the reproducibility And we have to keep in mind about the count whenever these applications are used, counting of non-neoplastic cells like normal epithelial cells or lymphocytes, and even the some brown pigment should not be overcalled. Just to give an example, that this is a node where there's a tumor, is actual tumor is here, but the area which has a normal lymphoid tissue shows high Ki67 proliferation. So algorithm should not pick these area, and at the same time sometimes the normal stromal cells or epithelial cells, they pick up the staining, so those should not be counted. uh, Another applications which is where AI can play a role, because counting of or evaluation of PDL1 is challenging, and there are some algorithms which are developing in this direction also, but uh, these are still in the development phase, because it is also the things which are more complicated for humans are also complicated for the machines. And although there are some good results, promising results has started coming, but still till date they are not mature enough, but many people are trying to test them. And even as we know that PDL1, there are various stains have different clones like Ventana SP263, which is more bright and crisp staining. So in those for using these stain, the algorithms gives more precise results, but the time will tell that uh, uh, which with the maturity of these algorithms in the clinical practice for the PDL1. Some promising results also has started coming for the biomarkers, like in GI cancers for the MSI, BRAF mutation status. There are very good promising results are coming up using the only the HE images. You can predict the mutation status, but for other biomarkers, it is still in the development phase. And this is a review article which was published last year, and which has showed that even there is a probability to pick up the MSI status even using these images as high as almost 90%. So it can save a lot of time and triaging, help in the triaging of the patients for these mutation testing. Another application where the now the our role is AI will take over, even if based on the H images can predict the site of metastasis also. So there is this paper was recently published where the prediction for colon, breast, and pancreatic and esophageal cancers was evaluated, and they found that for the colonic cancer, the metastasis in the liver was best predicted. So if you see the future of computational pathology, and so this paper has come last year, where they have evaluated around 180 parameters, and predicted that many of the applications or the things which are doing manually in current era will be replaced almost completely or partially by the end of 2023. So although these experiences are based on some people who are actually deeply into the field of computational and digital pathology, and for us it will take some time, but the time that time is not far away. And that's now the push is to use this black box to make it as a more explainable AI, rather than having only one way communications. Just to give you an example, if like for the Ki67, where the developers has to understand that even the various grades of the staining are relevant for the counting. So to conclude, digital pathology and AI have boomed up the pathology practice and market, and we have to geared up for it. And the days are not far away when the reporting and the diagnostic work will move towards the digital pathology. And if you don't get accustomed to it, there's always will be a fear that we might lose our job. But uh, this at this time, this is a very golden opportunity for us, because if we get engaged with the developers on understand these workflow more closely. So with the data sharing and collaborations, many of these developing these companies, they are approaching the pathologists or pathology departments. So you can closely collaborate with them, even if you don't have an in-house facility. you can plan to work closely with them and understand this whole process. And especially in the for the precision medicine, AI hold immense role for the prediction of biomarker predictions, especially because they improve the accuracy, consistency, and efficacy. And current AI methods has their own pros and cons, and but with time there is a definite improvement is going on, and these models are improving day by day, and hopefully they will come into the practice very soon. So so if you ask me, the future of pathology is at each and every step, you will see there is some role of these IT or AI based application, right from the specimen receiving to the routine diagnostic assay testing, as well as for the molecular testing. And this will be the your future pathology cockpit, where all the information you want on your screen, right from the radiology information to ISC based markers and the molecular profiling results, all should come and sit at one place. So although the journey is I agree, it is not a straightforward journey, but we should move slowly and slowly towards the digitalization. And my message, at the end, I will just like to say, just go digital, either buy, beg, or steal, whatever you have to go do for it, just go for it. With this, I end my talk. And uh, before I end, just like to invite, we are starting up with the Asian Society of Digital Pathology, and tomorrow we have a first seminar of that. And you can I've shared the registration link with the organizing team, or you can either share with among yourself, or you can just scan this QR code. And this is a free webinar which is being done tomorrow. And if you want to learn more about the digital pathology, and these are some of the topics which we are going to cover in this 3 to 4 hour session, which will start tomorrow at 11:30 a.m. in Indian time. With this, I end my talk, and thank you very much for this opportunity.
Thank you, Rajiv. Thank you so much for that wonderful talk. And I think everybody would agree that no one could have done a better job than you, Rajiv. Seriously, we can feel the passion with which you have put your heart and soul into digital pathology, and you have given us a very good overview of how to go about choosing a scanner. What are the different aspects when you go in for digital pathology, and the important value of how AI is going to get integrated into day-to-day practice. Uh, it's a great opportunity. It's exciting. At the same time, it does give us creeps, to say the least. In the sense, for the coming generation, it becomes imperative that they join the bandwagon early in this. Maybe not for me, or not for the people who are almost at the fag end of their career, but for the youngsters, it's definitely they will have to use and integrate AI into their day-to-day pathology practice more and more. Are there any questions, Dr. Shaini? Uh, I don't see anything. Yeah, Sirimberesan has a question, I think.
Yeah.
Yes.
Sir, thank you, Rajiv sir, for lucid talk, first of all. So I have a few quick questions actually. First thing, you have very clearly mentioned about the importance of clinical and analytical validation. Actually, what I'm seeing in the last 5 years, actually, when it comes to the diagnostic part, we are not giving that much importance to the validation, actually, whether being it's the imaging or being it's the genomic thing. So could you please enlighten us once again, what is the importance of the validation? If the validation is not done, and if we are using continuously, what will happen, basically? So that's the first question from my side, sir.
Yeah, so the validation of any technology, whether it is digital pathology or IAC or any test or the molecular test, it is very much important, because we are dealing with the clinical sample. It is we are not doing if we are in a research laboratory, it is still acceptable. Okay,